Assalamu alaikum, dear colleagues. I'm super impressed that everybody has stayed so attentive till the end of the day, and thank you for staying on. Thank you, Dr. Arshi, for the kind and generous introduction. So I'm glad that you all had your lunch, and we're not going to be facing any hypoglycemia. On the other end, what I will be discussing is the most frequent endocrine emergency that is managed in acute medical settings. I do not have any conflicts of interest to declare. So the outline of my talk is really to discuss DKA, diabetic ketoacidosis, primarily in adults. I am going to touch on euglycemic ketoacidosis because this has become an area of concern, and then just touch on hyperosmolar hyperglycemic state because the management is really quite similar. And the bulk of my talk is really based on the joint British Diabetes Society guidelines that were first published in 2013 and then updated just recently in March 2023. So this is a very good article for you to read, especially if you have insomnia. So DKA is on the rise. It may be on the rise because, yes, diabetes in general is a lot higher, but we're seeing increasing hospitalization for DKA. And Gulema Perez, who's been an advocate for inpatient glycemic management, actually talked about a call for action, a need to have some prevention programs. So data from the US is showing that there has been an increase of about 6.3% over the last decade, and the same has happened in the UK. What about our situation? This is data that we've not published, but as you can see, there has been this gradual rise in the number of cases that we have encountered in our daily practice from 2009 to 2019. This is just thanks to one of my colleagues who's right here, Dr. Tausif, who's responsible for keeping our key performance indicators, and she tracks, the number of cases that are admitted to the hospital, and this is our data for 2022. Now, I also have data from Tawam Hospital, from the capital, and this was published by Dr. Raya Al-Mazrui, who's going to be a speaker tomorrow. And also they showed that from 2017 to 2020, you've seen that there's been this gradual increase in the number of diabetes, or patients admitted with DKA, primarily the type 1 diabetics. So it's in the name, diagnosing DKA, you need D, the glucose, K for the capillary blood ketones, which need to be greater than 3 millimoles per liter, and A for the acidosis, as outlined here. Now, we have a lot of residents in the audience, and therefore, when we're thinking about the ketosis, it's also important to think about the DKA mimickers, I would say. So alcohol, starvation, just recurrent vomiting from any other cause, prolonged exercise, and ketogenic diets, which have become so popular, also should feature in as part of differential diagnosis. And then remembering that DKA is one of the differentials of a high in iron gap metabolic acidosis. So, we do exams and we all love to have mnemonics. So the mnemonics for a high in iron gap metabolic acidosis are highlighted there. You have your mud piles, so methanol, uremia, DKA being one of them, paraldehyde, not very common, iron overdose, lactic acidosis, and salicylates. And then on the other side, you could read that as gold mark, and you can just go down the list, and that's how you could remember, you're easy for the exams when you encounter your MCQs, but equally important when you're in the emergency. So what are the typical deficits that we see in patients with ketoacidosis? Well, they have about 100 ml per kg water loss, and then there's also loss of sodium, loss of chloride, and there's loss of potassium as well, as shown there. So the initial evaluation is really to determine the degree of severity and prioritize where the patient goes. Do they go onto the general medical floor, or do you need to send them into the ICU? We then look at the clinical evidence of hemodynamic instability, signs of respiratory distress, the degree of dehydration, what about the cardiac and renal function, their mental status, and we actively look for any precipitating factors. So the presence of one of more of the following listed here actually indicate a severe ketoacidosis. So if the blood ketones are greater than 6 millimoles per liter, your bicarb level is below 5, your pH is below 7, there's presence of hypokalemia on admission, the GCS is less than 12, the patient is hypoxic, hypotensive, tachycardic, and they've got an anion gap that's above 16, those are all indicators of quite severe DKA. And so you should consider immediate referral for ICU care when the patient's got a severe metabolic acidosis, they've got signs of respiratory fatigue, the GCS, as I said, is less than 12, and if your patient has associated comorbidities, so they've got signs of failure, they've got signs of renal impairment as well, because they will need much more closer monitoring of both their fluid replacement and the electrolytes. If the patient has associated sepsis or septic shock, that should also be a trigger for ICU referral. And then if you've started managing the patient and you can tell or see that they're not responding with the standard measures, then that should also be a trigger for prompt referral to an ICU setting. So in evaluating the precipitating factors, it's very important because you want patients, not to come back with another episode of DKA. So was this episode really triggered because of omission of their treatment? Is it an undiagnosed case of diabetes? Is there any evidence of infection? Are there other things going on? Maybe the patient has a myocardial infarction. As you know, in patients with diabetes, they may have silent MIs. Is there a concomitant pancreatitis? Or look for the drugs, because this is also important. Patients are going to go home and maybe continue taking these agents, the steroids, thiazide, diuretics, antipsychotic agents. And more increasingly, because we're using SGLT2 inhibitors, it's important to ask about these agents. Does the patient have any psychological problems and eating disorders? These need to be looked at before the patient is actually discharged. So we looked at our precipitating factors in the hospital, and we also found that poor compliance to therapy, so patients just stopping their treatment, was actually the most common cause for coming in with a DKA, followed by infections, newly diagnosed diabetes, so this is somebody presenting for the first time in DKA, pancreatitis, and then there was the others as well. So the principles of management are really quite simple. This is a life-threatening disease, but fortunately, because of the use of DKA pathways and protocols in hospital, the mortality rate is very low. So you need to have adequate fluid replacement, correction, of course, of hyperglycemia, correction of electrolyte disturbances, and the identification and management of precipitating factors, as I've just mentioned. So the universal agreement for the most important therapeutic intervention is the fluid replacement, followed by insulin administration. And the aims of fluid replacement are really to restore the circulatory volume, to clear off the ketones, and to correct the electrolyte imbalance. So the question is, which fluids? And the agreement also is that the initial fluid management should be sodium chloride, 0.9%. And then once your blood glucose levels fall, you can use a dextrose infusion. The JBDS recommend to use a 10% dextrose infusion in order to prevent hypoglycemia. And of course, you're all aware of the fluid replacement strategies. You need to rapidly correct over an hour, and then 2 hours, 4 hours, and so on. This aggressive fluid management, however, needs to be cautiously administered in, say, very young people aged less than 18, particularly if they're underweight, because then it would be better to do it based on their weight. Definitely cautious in elderly people as well, in pregnant women, in patients who already have evidence of heart failure or kidney failure and any other serious comorbidities. And these are the sort of situations which would trigger you to manage the patient in an intensive care setting. So reassessment of their cardiovascular status at 12 hours is always important to look at. It's not just put in the pathway and go on to autopilot, because patients may require to have further fluid management or, backing down of the fluids. So just looking at why 0.9% sodium chloride is advantageous, because we've had decades of clinical experience, it's readily available, and you have commercially available products which are already mixed with the potassium. The only disadvantages is this development of a hyperchloremic metabolic acidosis, which may cause then renal arteriovascular vascular constriction. The other agent that can be used if you don't have that, but that's quite unlikely, is to use Hartmann's. The advantage is that it is a balanced crystalloid with a minimal tendency towards development of a hyperchloremic metabolic acidosis. However, the disadvantage is that there's insufficient potassium if used alone, and it's not commercially available mixed with potassium. So those are just the things to be aware about. In terms of the insulin infusion, the recommendation is to have a fixed rate insulin infusion that's calculated at 0.1 units per kilogram body weight. And it has, the administration of insulin has several effects to suppress the ketogenesis, reduce the blood glucose level, and correct the electrolyte disturbance as well. And this is just an algorithm of how you would want to administer your insulin based on the patient's body weight. And then once your blood glucose levels start dropping down, you may reduce the infusion rate to 0.05 units, and this would be the algorithm that you might want to use. The other thing that's important is to make sure that the basal insulin is also continued. So if the patient is already on a long-acting basal insulin, continue on the same dose that they were before they came into hospital. But if this is a person who's presenting for the first time and you've just diagnosed them with diabetes, then you can administer it at 0.25 units per kilogram subcutaneously daily. Then the potassium replacement, the most important caveat is to make sure that the patient has a urine output before you actually give them the potassium infusion. We need to monitor that closely every 2 to 4 hours. The first liter usually goes in without any potassium. The second and third, you would require to have your replacement with at least 20 millimoles per liter. If the potassium is greater than 5, then no potassium infusion. And of course, we need to withhold the insulin infusion when the potassium levels are less than 3.2. And this would be sort of the potassium infusion in 1 liter of fluid based on the levels. So the initial investigations, and there's a battery of investigations in our hospital. We have the so-called DKA pathway investigations. And with one click, the emergency physician is able to activate all the things that you can see listed there on the list. And I'm not going to go through them in great detail. What are the metabolic targets? We would like to reduce the blood ketone concentrations by about 0.5 millimoles per liter per hour, increase the venous bicarbonate by 3 millimoles per liter per hour, reduce the capillary blood glucose by 50 milligrams per deciliter if you're in milligrams, or 3 millimoles per liter per hour, and then maintain the potassium levels between 4 and 5.5. If these targets are not achieved, then the fixed rate insulin infusion rate should be increased. When do we say that the patient is in resolution? When the blood ketones are really less than 0.3, pH is greater than 7.3, and the bicarb levels are about above 18 millimoles per liter. Once the DKA has resolved based on these 3 parameters and the patient is able to take well orally, we can then administer the subcutaneous short-acting insulin with the meal and then bridge them, so carry on the IV infusion for at least another hour to make sure that the patient has this overlap and prevent them from, say, going back into DKA. So the main changes have been in the standards of care now for the management of DKA is to use the venous rather than arterial blood gases when we're looking at the pH. Capillary ketone meters have become very useful, and they can be adapted for point of care testing. As I've mentioned, the choice of the fluid is 0.9% sodium chloride. Making sure that the subcutaneous long-acting basal insulin is on board. Insulin is administered in a fixed rate calculated on the body weight. And please, please, please do not use a priming bolus dose of insulin as people used to do so in the past. So the other recommendations, as I've mentioned already, is to consider reducing the rate of the insulin infusion to 0.5 units when the blood glucose levels start dropping. As I've mentioned before as well, cautious replacement in special groups. Bicarb administration is not recommended routinely, neither is a phosphate infusion or replacement. Now, a word about DKA, because we always have this argument with our emergency physicians. There is really no robust data suggesting that the routine use of bicarbonate infusions in moderate DKA actually improves the outcomes. On the contrary, it can actually lead to more problems. So a rise in serum keto acid and iron levels may delay the resolution of the ketosis. There may be a paradoxical worsening of the acidosis within the CNS, and that may lead to neurological deterioration. In a pediatric population, they're more prone to develop cerebral edema. There's worsening of the hypokalemia, which in turn may precipitate fatal arrhythmias. There may be worsening of tissue oxygenation because of the acute reversal of the acidosis, and there may be post-treatment metabolic alkalosis as well. So if you are going to give a bicarb infusion, please think and ask yourself, is this really necessary? So when does it become necessary? You might consider giving a patient IV bicarb if the pH is less than 7 and has not improved after 1 hour of fluid resuscitation, and if the patient has other comorbidities that necessitate bicarbonate. If you are going to administer it, then start slow, 50 ml, 8.4% in 100 ml, give it over 2 hours, and then you can reassess. There's no need of, bombarding the patient with 200 mils, as sometimes we see, because then, you have all those problems that might arise. Thinking about the special groups, I've already talked about elderly, pregnant women, young adults who are underweight, presence of heart failure or kidney failure, acute pancreatitis. These are situations whereby we would need to have an intensive care setting. You wouldn't want to put these individuals in the general floor. Now, what about euglycemic ketoacidosis? Another important entity that we should be aware of. This is the development of a raised anion gap metabolic acidosis or significant ketonuria in somebody who is known to have diabetes, but the glucose levels are normal or not particularly raised. And improved education in people with diabetes with increased home capillary glucose and ketone monitoring might have led to this partial treatment of ketoacidosis prior to them, presenting to the hospital. It is treated in exactly the same way as hyperglycemic ketoacidosis. And the initial glucose administration is to give 10% dextrose straight away at 125 mils per hour, because you know that the glucose levels are less than 250 milligrams per deciliter. And then you can also begin with 0.1 units per kg per hour of your insulin infusion rate. When the blood glucose starts dropping, you can then reduce that by half and give them at 0.05. The underlying mechanism is either due to a decrease in the hepatic glucose production during the fasting state or an enhanced urinary excretion of glucose, as occurs with the SGLT2 inhibitors. So some of the common causes include pregnancy, pancreatitis, cocaine intoxication, prolonged vomiting or diarrhea, the use of the insulin pump, and SGLT2 inhibitors. Now, the SGLT2 inhibitors do this fortunately not so commonly, but when it does occur, this is the sort of potential mechanism. You have a reduction in the plasma glucose level as a result of glycosuria that kicks in your counter-regulatory hormones, more of glucagon, less insulin, you increase your lipolysis, increase ketone production, and therefore the ketoacidosis. This was a paper that I saw that was also published from Abu Dhabi by Dr. Raya, and they looked at the patients that presented with DKA associated with the use of SGLT2 inhibitors. So something to be thinking about. Just some pitfalls. I know I'm running out of time. Think about alcoholic ketoacidosis as well when you have normal glucose concentrations. But then remember, is this another differential for euglycemic ketoacidosis? Ketoacidosis without a raised, can I have my slides back? Just 2 more to go. I've run out of time. Can we have the slides? Yeah, so a raised glucose in a person with alcoholism is usually quite diagnostic. And then if it is suspected, this is the important part, use a capillary beta-hydroxy butyrate and not the urine ketones, because the acetoacetate production can be suppressed in alcoholic ketoacidosis. So starvation ketosis as well, there will be a history. There's been lack of carbohydrate intake, usually developing over several days. Right. So some of the complications, listed there: cerebral edema, cardiac arrhythmias. Then just a word about, HHS, much less frequent. These are the sort of differences that we see: much more profound hyperglycemia. The bicarb levels are normal in the case of HHS. They don't have any ketonuria, and the serum osmolality usually is the differentiating factor. Mental status may be obtunded in both cases. Management is exactly the same. And just to consider about the pre-discharge considerations, I've mentioned about identifying the precipitating factor, reviewing the patient's glycemic status, their injection techniques, those on pumps, reviewing the devices that they're on. We want to prevent recurrence, so making sure that the patient is going home with their written sick day rules. Looking at the insulin effectiveness, has the insulin that they're using either expired? Assess the need whenever necessary for handheld ketone meters. The provision of a contact number for troubleshooting. So they need to have a contact of the diabetes specialist team for out of office hours so that they can consult someone. And then those who come in with recurrent admissions, and I'm sure you have those in your practice, is there a psychological element? Do they have eating disorders that needs to be addressed before the patient is discharged from hospital? So I'll skip that and just summarize that it's one of the commonest endocrine emergency. Management involves prompt initiation of fluids, insulin, and correction of the electrolyte abnormalities. And they've blocked me because I have run out of time. Anyway, thank you for your attention.